So to tell you a story, before we get into what I'm supposed to say, and my team loves it when I go off topic, Baptist Health, it's easy to see this now as a system and how it's already created. But actually, Baptist Health started, as I said before, with MCVI as their first center of excellence, which now we call institutes. But the story is this, when folks were coming for cardiac and vascular care, then they started asking, do you have an orthopedics program? And so that's how Baptist then later on, through the work of Dr. Uribe, the work of Dr. Heckman, VJAC, and then all the leaders that they brought in, it made all the difference after. So our second center of excellence, which is our second institute, was actually orthopedics. And it's really pretty cool when you're watching. I'm a football fan. Miami Dolphins are not doing too well, but we're still there. But when you're watching your team, right? You're watching your team on the field taking care of those million-dollar athletes. It's pretty cool. And they take, like they said before, taking care of the Miami Heat, the Florida Panthers that won the Stanley Cup, and anything from the Miami Tennis Open to the ballet. So we have an amazing team, and they were able to modify things from just being general to getting down to specifics. So with that, we're now going to begin our session, continue session with our experts from the Baptist Health Orthopedic Institute. The moderator for this module is Dr. Charles Jordan. He's the Medical Director of Orthopedic Trauma Surgery. Dr. Jordan will be joined by Dr., I'm going to get this right, Dr. Alexandr Aylyarov, I hope I got it right, Orthopedic Sports Medicine Surgery, Dr. Juan Suarez, Orthopedic Hip and Knee Surgeon, Dr. Elizabeth Olette, Medical Director of Orthopedic Hand Surgery, Dr. Carrie Chapman, Medical Director of Orthopedic Foot and Ankle Surgery, and Dr. James Ross, Orthopedic Surgeon, Director of Joint Preservation Surgery at Boca Raton Regional Hospital. And with that, Dr. Jordan.
Okay, thank you, everybody. Hope everybody was able to get some coffee. I'm Charles Jordan. I'm one of the orthopedic surgeons at the Baptist Health Orthopedic Institute. My focus is on orthopedic trauma and reconstruction after post-traumatic injuries. I think that what you'll see from the speakers today is the breadth of injuries that we cover, the state of the art that we try to stay on top of, and what I call the greatest boon in being able to be part of this group, which is that we have physicians and colleagues that every single one of us would send our friends and family to, and have, and continue to. So the first thing that we'll do is we'll start the presentations, and so I believe that Dr. Aylyarov is the first one, right? Are you the first one coming up? Dr. Aylyarov has joined us recently after having been a fellow with us with Dr. Uribe and Heckman and VJAC and the rest of the sports medicine group. We're very lucky to have him. We're very lucky to have lured him back. And so without further ado, here's Dr. Alex Aylyarov.
Thank you, everybody. Thank you to Baptist Health International for putting this together. I was sitting in the back learning about what our M&I partners are doing, so hopefully we can teach you a little bit about what we're doing at the Orthopedic Institute. So my topic today is going to be talking about meniscus tears and kind of the current concepts surrounding the subject. And really, there's been a paradigm shift in how we think about meniscus tears. I was on social media a couple months ago, and there was a hashtag, a trending topic, hashtag save the meniscus. So if you remember nothing else, hashtag try to save the meniscus. So I've got no disclosures relevant to this talk or any talks. So we're going to start with a little background. We'll start with a little bit of anatomy. So the menisci are these unique bundles of collagen. They sit between our femoral condyle and our tibia. And historically, we thought of them as these non-functional remnants. And we later learned, of course, they're important in both knee stability and in our force distribution. And so the medial meniscus tends to be a little more C-shaped, our lateral meniscus a little more U or O-shaped configuration. And the lateral meniscus tends to have a little more variability in its shape and its size, like we see with a discoid meniscus, and tends to be a little more mobile. So we've got multiple anatomic studies that looked at the interplay of the menisci with other structures in the knee. And so the stability of the knee is affected by many of these structures, including the root attachments, the intermeniscal ligaments, the MCL. And more recently, we've identified some important meniscofemoral and meniscotibial ligaments, which can relate as it relates to extrusion. So the orientation of our collagen fiber also is important, and how they play a critical role in the function of the meniscus. And the orientation is ideal in transferring the compressive loads of our body into these circumferential hoop stresses and distributing that load appropriately. And so the meniscus tear disrupts this orientation, and they can make the menisci function poorly or completely non-functional. And so, as I mentioned, they play a huge role in load bearing and in shock absorption. And so multiple studies have shown that tears or even partial meniscectomies, like we used to do a lot of back in the day, decrease the contact area and can increase stresses across our femorotibial joint by up to 235%. This can allow for increased anterior translation of the femur on the tibia and the compressive forces, which then can lead to arthritic changes in our knee. The blood supply is also critical as it relates to the meniscus. And so it's supplied by the perimeniscal capillary plexus, which originates from the capsule in the periphery of the meniscus and then goes centrally. And so this leads to this gradient of vascularity with a highly vascular peripheral zone, also known as the red zone, and a more central avascular zone, which is our white zone. And so this really affects how our tears heal, and so really have to think about that as we progress in this talk. And so the prevalence of meniscus tears is highly prevalent. So it's one of the most common things I see in my office. Up to 20% of, 10 to 20% of all orthopedic surgeries in the US involve some sort of meniscal tear. Historically, like I mentioned, they were considered functionless and they were just taken out. Of course, this led to significant degeneration. Newer biomechanical studies suggest almost always repairing a meniscus, but again, these biomechanical studies, they don't take into consideration the actual host, the patient, right? So you have to consider factors like continued pain, healing potential, or costs associated with reoperations if you have a failed repair. So we have to think about which ones to repair, and we have to consider healing potential, which can include multiple factors. So one of them being the location of the tear, along with its vascularity, the tear pattern, the chronicity, and the mechanism of the tear, whether it's a degenerative or traumatic type tear. One of the other things that's important is think about whether it's an isolated meniscus tear or there's some other ligamentous injury, right? So we've learned that meniscus tears heal significantly better when there's a repair, when it's done in association with a ligamentous reconstruction like an ACL. And so how can we use that to improve our current healing? Of course, there's also discussions of normal mechanical alignment and whether we need to do like a adjacent HTO at the same time, high tibial osteotomy. So as we consider which patients may benefit from a repair, we also got to consider which factors allow for improved healing. And the first one we have to talk about is improving biology. And so, as I mentioned, we looked at those studies that showed meniscal healing is significantly higher in those patients who have ACL or PCL reconstruction done at the same time. And in some studies, that was about a 90% healing rate compared to only 50% when they're isolated. And so we theorized that this was due to the release of multiple growth factors and pluripotent cells when drilling those tunnels. So if you can see in this picture here, that big giant tunnel that we drill, imagine all the marrow elements coming out of it, which can help our meniscus healing. And so how do we get a similar biologic environment when we're dealing with an isolated meniscus tear? And so one way is to do what's known as mechanical abrasion, right? We use a rasp or a shaver, we go in between. This is like a horizontal type tear with a leaflet on the top and the bottom, and we can abrade the periphery, which is, as I mentioned, is where we have all of our blood vessels, to get a little bit of bleeding in those growth factors coming out of our blood vessels inside the tear. Some studies demonstrated that even just trephination, using a needle to poke holes in that area, can increase our results by 90% good to excellent results. Marrow venting or notchplasty, so replicating what we do with an ACL, we use these awls to poke holes in the non-weight-bearing intra-articular notch, replicating what's done with ACL reconstruction, getting that marrow elements coming out. And so studies have shown that results can be equivalent to what we see with concurrent ACL reconstructions. Platelet-rich plasma, so of course one of the hot topics in orthopedics. We try to use it for everything we can. The data isn't as clear for this one. There's some studies that do show that there's an improvement in pain and function outcomes at 1 year, but when we actually look at the MRI studies or the second look arthroscopies, healing rates appear to be the same. All right, so the next thing we have to consider after biology is improving our techniques. And so one of the first things I learned was the ABCs, right? And so in meniscus repair, that stands for anatomic reduction, biologic augmentation, and circumferential compression of your repairs. And so this philosophy kind of gives you the best chance of success, but how do we actually apply that? And so as we transitioned from an open to an arthroscopic repair technique, we started to have to figure out how do we best repair these menisci. The gold standard became the inside-out repair, where we passed needles through from the inside the knee out, and we tied it on the outside of the capsule. And then we started to develop outside-in techniques, all-inside techniques, transtibial repair techniques, and then using a hybrid or a combination of all of the above. And so newer studies show that when done correctly, there's no difference between using the new all-inside second-generation techniques compared to the inside-out, which is, again, our gold standard. So here's an example of what an inside-out technique would look like. So that's a sagittal MRI showing the bucket handle type tear with, you can see a double meniscus kind of in the back of the knee there. In that coronal image, you see, again, a little piece of meniscus or a big piece of meniscus stuck in the center of the notch. And so this is the intra-articular arthroscopy. And again, you see that big flap of meniscus sitting right in the notch. And when we go to the medial compartment, you can see the entire plateau with the meniscus being in the notch. And so as we reduce the meniscus, you pass needles through these metal cannulas and you tie them through a separate incision on the outside of the knee. Now, this technique, again, although the gold standard, has some negatives. One, you have to make separate incisions. Two, you need multiple hands, right? Somebody has to throw the needle, somebody has to catch the needles, and there's always the risk of needle sticks with that. So we started to develop other techniques. And so outside-in techniques are also really great, but they really only work for our anterior horn or body tears, where we pass needles from the outside through the skin. And then we pass the suture through the needle, and again, it's tied through a separate incision. But again, the negatives being it's only can be utilized on the anterior horn of the body, and has to be a separate incision has to be made. So we've started to develop these all inside. Multiple companies have them now, but there's been multiple iterations, where the first iteration we used these darts or these tacks, and they failed terribly. And so we've mostly abandoned those. But now these newer implants utilize a device that will pass these anchors, whether they're PEEK or newer ones that are all suture, to across the tear into the back of the knee or the back of the capsule. And then they anchor it, and they have a self-tensioning type device. There's other ones that, like this one, for example, is a knotless type mechanism, and it self-tensions, but there's other ones that you can tie knots with as well. The benefit being I don't have to make a separate incision. I can pretty much do it by myself without any additional help. So we're going to talk about how these different techniques can be utilized in different tear patterns. So vertical tear patterns generally have a very high healing potential. They're very generally often peripheral and vascular, and can often heal very well. But we can oftentimes miss these, and these can progress to a big bucket handle tear like I showed earlier. And also, they've been shown in people who, where we've missed these vertical tears, and we've had to do, for example, an ACL reconstruction, they've had higher failure rates of our ligamentous reconstruction in those patients, which really shows the importance of the meniscus to the stability of our overall knee, and not just what we thought about as in terms of shock absorption. And so again, historically, these were treated very well with an inside-out type repair, like you can see there in panel A. So we would pass the needles and we would tie it over the back of the capsule. But what you can see here in panel B, now we can have the same type of construct using these all-inside type techniques. Now what's important, again, the first thing remember I mentioned is the ABCs, the anatomic reduction. You know, in panel B, it looks great, but you can see there's a little gap on the bottom. And so it's really important that you have to do a separate, put a separate anchor on the bottom of it to really close that gap down where you're recreating what you see in panel A. Panel C there shows another type of all-inside type repair, but in this case we would tie a knot on the top of our meniscus again to close that down. And so this is what I mentioned earlier, one of those new implants that uses all suture, so there's no plastic or that peak that I mentioned, potentially if it fails, floating around in the knee. It's all suture, which is much softer to the cartilage. Horizontal tears, they're slightly more complicated because they pass from our avascular to our vascular zone. And historically, what we would do is we would just take out one bottom leaflet or the top leaflet, whichever one was smaller, and we would say that's good enough. But what we've learned in multiple biomechanical studies is that just taking out one leaflet increases our contact forces by up to 60%, which, again, in biomechanical studies, is essentially like you're taking out the entire leaflet, or both leaflets. And so we've started to look at how repair can bring down those contact forces. And again, in biomechanical studies, you can bring it back down almost to normal. Now, what's important in these types of repairs is again, the host. So these are often seen in degenerative type tears in the older population. And so, again, we have to figure out ways, potentially with biological augmentation, to really get these to heal. And so one of the important things to consider is really getting good compression across your repair site so you don't get any synovium leaking in and causing failure of your repair. So again, I showed this picture earlier, but it really highlights this. So that horizontal tear on the left, you get really good circumferential, what we call these hay bale stitches around the entire meniscus, compressing across your repair site. And so again, either using that abrasion of the back of the knee or fiber and clot would be really good in this case to augment our repair. And so again, this is one of the new type of devices that have been developed where you can tie these hay bale type stitches in an all-inside type repair without having to come back out of the knee or without having to make a separate incision. So again, as I mentioned, these have historically had believed to have poor healing rates, but newer studies really show that these healing rates can approach 80%, which is much, much higher than we originally thought. Now, of course, younger patients, acute type tears, still do better than the older degenerative type tears. But again, our repairs are healing at a higher rate than we thought before. So you really need good compression across the tear site. And really, this is one time you really want to consider that biologic augmentation. Radial tears are also, again, very common, and they also involve both the vascular and avascular zone. And these were historically fixed with inside-out sutures, which are tied on the outside, as I mentioned earlier. But that creates a horizontal mattress type configuration, which, again, biomechanical studies have looked at, and that's inferior to a vertical mattress type configuration, which we can get with these all-inside, side-to-side type repairs. And so the biomechanical studies show lower displacement, higher load to failure, and greater stiffness when you use these all-inside type devices. So hopefully this video works. There you go. So this is just a quick video looking at one of these radial tears. And again, just to orient your femur on top, tibia on the bottom. This is the lateral meniscus. We can see the popliteus in the back, and you can see this big oblique type tear going across our entire posterior horn of the meniscus. And so first thing you got to do is see how mobile it is and really figure out where the anatomic reduction is going to fit. And so in this case, we're using that similar type of all-inside type repair where we they would pass the suture on one leaflet. And again, not having to come out of the knee to reload this device saves time. It saves you potential damage to the cartilage as you're doing it. And then, again, doing it on the other side, and then we tie it over the top. So again, this is your complete, one type of complete reconstruction, again, utilizing those vertical mattresses, which are known to be much, much stronger. In this case, the authors actually did a second look, which we'll see in a second. So with a vision needle scope. Now, the quality isn't as good on those vision needle scopes, but it's essentially a camera at the end of a needle. But you can see 8 months later, you have a healed meniscus repair. A lot of people ask what happens to the knots, what happens to the sutures. Usually they just synovialize over and they don't cause any issues to the cartilage. So root tears, again, this is a really, really important topic, something we've neglected for a long time and have really been recognized as more and more important over the last decade. They were first described in 1991, and they're a complete radial tear within 1 centimeter of the attachment, or a bony or soft tissue avulsion. And often these were missed, but we noted that failure to recognize them led to really, really rapid deterioration of the knee. And biomechanical studies show that this is essentially equivalent to taking out the entire meniscectomy. And so we often saw this entity we called SONC, right? Spontaneous osteonecrosis of the knee. When we looked back at a lot of those cases, approximately 80% of those cases, we missed a posterior root tear. And that's what led to these spontaneous AVN of the knee. And so in other studies, it was shown that non-operative treatment of these tears led to total knee arthroplasty in up to 30% of the patients. So this is a depiction of what the contact pressures look like in a knee, again, in a biomechanical study, in a normal meniscus, compared to what it is in the middle section, which is a total meniscectomy, versus the right panel, which is a root tear. And you can see those really high blue ones where you have really, really high contact forces, which look very similar between the total meniscectomy and a root tear. So what do we see on MRI? So again, this is a coronal image here, and you can see that complete radial tear right at the root attachment. Here in the central picture, it's what we call, just to orient you again, to the left would be the front of the knee, this would be the back here. So you can see a normal anterior horn of the meniscus, but in the back you got nothing. So we call that the ghost sign, so there's completely nothing there. And then one of the other entities that we've been seeing and recognizing more of, which I'll talk about in a bit, is this extrusion, right? And so which one comes first? Does the knee extrude that leads to the root tear, or does you get the root tear that leads to the extrusion? And do we really need to do anything about this extrusion or not? So this is what it looks like in an arthroscopic picture. So you have the complete radial tear right at its posterior attachment. And this is how we fix it. So we drill a transtibial tunnel, which again gives you that really good marrow elements to heal everything. We put some sutures through the end of it, and we dock it down into the tunnel. This just shows you what the guide looks like to drill that tunnel. And this is what just a depiction of the final construct. We either tie it over a button on the front of the knee or dock it into an anchor. Again, another quick video just showing this root tear. In this case, they've already drilled the tunnel and they've passed their suture. But you can see again that root tear goes all the way to the back. And even though the rest of the meniscus looks completely normal, that's why you really got to check for these, because they're oftentimes very, very hidden. And so they pass these luggage tag, like when you at the airport, you put your name tag on your luggage tag type sutures through the base of the meniscus. Usually we do 2, sometimes 3, with this suture passing device, and then it's brought down and docked into the knee, which we'll show you in a second here. So again, here he's tightening down that luggage tag stitch. He's pulling down the suture coming out of the front of the tibia, and you can see how well it really, really reduces really nicely right there. I want to show you, he's going to come out of the knee, he's going to tie that anterior, tie it on the front of the anterior tibia, and then when he comes back in, a couple things I want you to see here. So here he's coming back into the knee. First, you see all that blood and marrow elements covering our repair site, which is, again, that biological augmentation you really get with this type of transtibial repair. And we're thinking about using these transtibial repairs in other type of meniscus tears because we really like that marrow venting. But again, you can see how stable that meniscus is now. So what are the outcomes with these root type repairs? So they're very promising and generally highly support surgical intervention. One study looking at 91 patients only had 1 conversion to total knee at 7 years. Meta-analysis comparing repair to meniscectomy to non-operative treatment in these root type tears looking at 10 years, 53% of repair patients had progression of their osteoarthritis at 10 years compared to 99.3% in meniscectomy and 95.1% in non-operative treatment. And then looking at conversion to total knees at 10 years, it was 33% in the repair group compared to 51 and 45 in the meniscectomy and the non-operative treatment. And so in this study, they said not only is it clinically superior, but economically more superior. You're going to save money in the long run without having to treat this worsening arthritis and potentially convert to total knees. So the last topic, and I mentioned this briefly before, is meniscal extrusion. And this is something that's kind of, we're looking at new developing in the literature right now. And it's displacement of our meniscus outside of the margins of the plateau. And again, it's often seen in conjunction with our root tears, but we're not really sure, it's not always seen together. And so we're not really sure, does one lead to the other, which one comes first? But we do know it's caused by tearing of our meniscotibial ligaments and leads to progression of arthritis. And so this brought about the idea of centralization, where we bring that meniscus back into the compartment, whether you do it in conjunction with a root repair or independently. And so this is just, again, this is new, so I don't really have any arthroscopic pictures to show you, but this is kind of what the idea is. You can dock, this is one method, you dock an anchor right at the proximal tibia, and you repair through an incision that meniscotibial ligament, pushing that meniscus back in the knee. The other way is, again, doing a transtibial type technique where you put some sutures through the center of the meniscus, you pull it back in, and you dock it on the anterior tibia. So in summary, meniscus repair leads to improved biomechanics. So whenever you can save the meniscus, it's not always possible, but utilizing improving biology, improving our techniques, and improving our identification of the type of tears, you can get better outcomes. So thank you very much.
That was a great job, thank you. So now going onwards in the journey of the patient after we've tried to save their meniscus is a man who's made an entire career out of trying not to save menisci. He's a total joint replacement, adult reconstruction, hip and knee specialist, and my family's total knee surgeon, Dr. Juan Suarez.
So good morning. That looked like very difficult surgery to do, so I do a little bit simpler surgery. So my job is to replace hip and knees, and I know this is kind of a niche topic, so hopefully I don't bore you too much. So I'm gonna try to keep it as simple as possible. So my task today is talk about using robotic surgery to do difficult knees and revision knees. Where do I point? Okay, so these are my disclosures. They're really not relevant to this one. So if you look at the American Joint Replacement Registry, you can see a big spike in the use of technology to do total knee replacement. This doesn't distinguish between navigation or robotics, but you can see that in the United States, it's approaching 15% of all the knees that are done are being put in with some kind of technology. And if you look at the knee that's most commonly used is the Stryker triathlon knee, and there's no coincidence that the most used robotic system in the country is the Mako system because it's attached or married to that implant. So you can infer from this information that the Mako system, at least in the United States, is gaining a lot of traction. So the Mako is a CT-based system, so the patient needs to get a CT scan before the operation. And the advantages of it in the primary setting is, when the patient has previous hardware, you can avoid the hardware and it can actually help you remove hardware. It gives you real-time information in surgery in terms of soft tissue alignment, soft tissue laxity, alignment, and that kind of stuff. And then you can manipulate your implant position accordingly to kind of get to where you want to land, and then the robot executes it pretty accurately. So basically, you can personalize the operation. In the beginning, there was a lot of reluctance to, is it worth spending the money in these devices, and do they make patients do better? And the reality, in the beginning, there was not a lot of literature that would support it, but now there's a lot of literature supporting that potentially with these kind of technology, you can get better pain scores, reduce the length of stay, improve implant positioning, and potentially get better functional outcomes at a year. So there's more of this data coming out now. In terms of revision, so let me backtrack a little bit. So the way we do it, the patient gets a CT scan, and then in surgery, what we do is we register the femur and the tibia. So we get 40 points on the femur, and what you're trying to do is tell the system, hey, this is where the knee is, so that it can marry the CT scan to the surgical field. So you get 40 points on the femur, you get 40 points on the tibia. I don't know if I think they uploaded the wrong talk, the non-revised talk, but I guess I can continue here. But that's not the last talk that I revised. So once you register the femur, then you register the tibia, and you have a pre-made plan. And then once you have that pre-made plan, then you do soft tissue balancing. And you can see, if you look at the video on the screen over there, we're tensing the flexion gap, and it's giving us information in terms of laxity. And by doing that, then you can adjust the implant positioning to satisfy what you think it's a balanced knee. Yeah, there was a bunch of slides that are not here. So what about using this technology for robotics and complex surgery? So it's off-label for revisions. So the company, the company won't support it, but you can do it and get around it. And there's a lot of benefit from it. Number one, removing hardware, getting around hardware, also getting the information in terms of laxity and the anatomy so that you can recreate the knee as it is intended to be recreated. So let me show you just a couple of examples. This is a patient that had a proximal tibial osteotomy and varus, which is something that you really shouldn't be doing, but it was done. So there's two difficulties here, the deformity and the pre-existing hardware. So traditionally, you would try to make a cut that's perpendicular to the anatomic axis, but if you can see on the medial side, you would have a lot of bony defect, and also there's hardware that would be in the middle. But with this system, you can change the angles or adjust the angles of both the femur and the tibia to accommodate for these malformations or deformities. And in this case, if you look at your bottom left, we're cutting the tibia in 4 degrees of varus, then we're cutting the femur in 8 and 4 degrees of valgus to accommodate for that. And then you can balance the knee properly, and then you can see how in this case, we did not have to do a corrective osteotomy, and we selectively remove some of the pre-existing hardware. So again, it allows you to adjust the bony cuts, and then it allows you also to remove hardware and minimize the exposure to remove that hardware. Then there's another case like this. You can see the patient has a pre-existing nail in the femur, and the nail is pretty distal. And anybody that has done this kind of operations knows that taking this hardware is probably the hardest part of this whole operation. But with this, you can actually start adjusting the positioning of the implant to try to avoid removing the implant, right? The nail. So in this case, we distalize the femur as much as possible, and we were able to accommodate the femur without having to remove that nail, which would be very morbid if we would try to do that. Then there's cases like this. This guy also has a proximal tibia deformity from prior osteotomies. He also has a long stem on the femur from a prior surgery of the hip. So there's a lot of variables here that trying to do this with manual instruments is very difficult. You can see this is what he has on the hip side. So in this case, we can accommodate the femur and also the tibia adjusted accordingly to manage that proximal femur deformity and avoid using standard instrumentation. And then you can see how you can, get the implants right where you want it without too much morbidity. This is another example. This is a failed partial knee replacement. If you look at your right-hand side, you can see that the tibial component collapsed, and there's a big femur defect there. When you can register the metal, obviously when you get CT scans, there's a lot of metal scattered, but you can still do the registration and pass the registration as long as you're careful, and sometimes it takes a couple times, but you can pass it. And then once in the planning phase, you can see that if you look at your right-hand side on the bottom, if you put the implant kind of in the standard position, you still have a huge bone defect there. But with the Mako, you can drop the cut to that level, and accommodate a cut to put a metallic augment there. And you can see here, you have a 10 millimeter augment on the medial side, and the Mako allows you to do that pretty easily. And then you can do full revisions. It's a little bit harder because there's so much metal that passing the registration part is not that easy, but you can still do it. You register on the metal and on the bone in 3 planes, and after a couple of tries, you can probably do it. And then again, you adjust the implant positioning to accommodate for the bone loss in the planning phase of the operation, and you can do cases just like this where you have hardware in the middle and you're accommodating for bone loss. So I'm sorry that all my slides are not there. I had a lot of videos to show, but I apologize for that. But in conclusion, robotic and knee replacement is gaining a lot of traction in the United States. I think CT-based robotic systems are much more accurate than non-CT based. I think there's a potential for improved outcomes, and the revision applications appear promising, and there's a lot of us doing it off-label, but it definitely helps with these cases. So thank you so much for your attention.
Thanks for that. It's a talk that's really showing what the state of the art is in total joint replacement, which is pretty fascinating. So coming up next, I believe, is Dr. Chapman, right? Are you next? So Dr. Chapman was a former professor of mine at NYU, and somehow, even though he knew I was here, he still decided to come join us. So this is Dr. Chapman. He's the medical director of foot and ankle surgery and a close friend.
Hi, good afternoon. I guess I'm just waiting for my talk to come up. But I am the medical director for the foot and ankle service at Baptist Health. We do a lot of great things. We're on the forefront of several innovative procedures, one of which we're going to talk about now. And essentially my talk is about a minimally invasive or less invasive way to do ankle fracture surgery. So essentially, when I was in training, and pretty much up until the last few years, I'd say the gold standard for treating an ankle fracture was called open reduction internal fixation, basically using plates and screws to realign and fix the bones, and it's very reliable, it's reproducible, and I would say usually quick and easy. So when you have a procedure like that, why bother changing, you know? It's hard to change your practice patterns when your open procedures are doing fine. I'll put that in quotes. But in orthopedics and like in a lot of other fields, we're making this move to MIS or to go smaller. So you've seen that with the first talk today. They're doing in sports medicine these all inside arthroscopic meniscal repairs. They're doing that for rotator cuff, shoulder instability. You'll see that in hand surgery, endoscopic. Carpal tunnel releases, elbow arthroscopy, spine surgery. In the last decade or so, they've gone to these minimally invasive fusions and microdiscectomies. And finally, in foot and ankle, we kind of lagged behind a little bit, but there are percutaneous techniques to doing Achilles tendon repairs, ankle arthroscopy, and minimally invasive bunion and lesser toe deformities. And so today we're going to talk about, I should say, less invasive, not minimally invasive ankle fracture fixation. So what we're really talking about is something called a fibular nail. The advantages of using a nail as opposed to a plate is that you have these smaller incisions and you strip away less of the soft tissue, there's less vascular disruption, less swelling and post-op discomfort. And the nail itself is a load-sharing device. So theoretically, you can have the patients walk on it faster. And when preparing the nail, you're doing something called reaming the canal, and that creates bone grafts. So maybe it lets the bone heal faster as well. So fibular nails have been around for a long time, actually. And if you look back at the history, the results are okay, not great. They tended to have lower wound complications, but there was a higher rate of the implant failing, and mainly because of this loss of, there was no fixation proximally, and the reduction would be lost. Let me see. So these more modern implants have, you can see the picture on the left, almost like a corkscrew, and on the right, there's these little talons that kind of come out. So it holds the fracture proximally. So once again, back in the history of these nails, they really had limited indication. So someone with really poor skin, a vasculopath, diabetic, elderly, someone with renal disease. But when looking at the benefits, why limit these benefits to patients who have poor soft tissue? So it's not just a cosmetic issue. I mean, honestly, if it were me, I'd rather have the incisions on the right than on the left. There are other reasons to have it, and this is once again me explaining that it's not really minimally invasive, it's less invasive. The percutaneous incisions you see on the left are maybe about 5 to 10% of the cases, and most of the cases are what you see on the right, where there's maybe a 2 to 3 centimeter incision. If you look back at the literature, comparing fibrillar nails versus standard open reduction internal fixation, there's decreased rates of infection for fibrillar nails. No real differences in patient-reported outcomes in the first study. In the second study, the fibrillar nail group had a lower rate of infection, but the patients that the fibrillar nails were used on were much older, and they had more comorbidities. There are some other comparative studies. Here's a randomized controlled study comparing fibrillar nails versus plate fixation. There's no difference in terms of the patient-reported outcomes, but significantly less wound infections in the fibrillar nail group. And when looking at the bottom line, it ended up that the fibrillar nail group ended up being less expensive, even though the implant most likely is more expensive compared to a plate. Here's some other studies, no difference in union rates, but this one showed a significant improvement in patient-reported outcomes for the nail. And once again, in terms of complications, there are significantly less complications with the nail compared to the plate. Here's some more studies showing the same thing. I'll just highlight the second one, which was done at Baptist. A colleague of mine had 100 consecutive nails with no infections or other complications. So in terms of how else can we make this a better surgery, when I was a resident, we would just fix them. We would never really look inside the ankle, even though the ankle joint was damaged. So now in many instances, we'll use arthroscopy. So we'll look inside the ankle at the beginning of the case, and this helps us identify and treat cartilage injuries, ligamentous injuries, instability, loose bodies. It can also help you confirm the quality of your reduction afterwards, and also importantly, to document what's going on inside the ankle. So you can tell the patient after, you had this bad injury inside the ankle in addition to your fracture, and that might be a reason why you're lagging behind in your recovery. So there are some studies just confirming the prevalence of these intra-articular injuries, such as on the top, the soft tissue hypertrophy, on the right, loose bodies, and then on the bottom, the chondral injury. Oop. Did I just go backwards? Yeah, I did. Here's a study comparing standard open reduction internal fixation versus open reduction internal fixation plus arthroscopy. And the patient-reported outcomes favored using arthroscopy in conjunction with fixing the ankle. And there are other studies showing that the actual fracture hematoma itself, the inflammatory factors in it, are cytotoxic. So arthroscopy actually helps you get those inflammatory factors out of the ankle joint. A little step up in technology. In the last 5 to 7 years, they've come up with these smaller arthroscopes. These were initially designed to be used in the office. So this particular one's called the nanoscope. The setup in the OR is actually, it takes up a very small amount of space. So for those of you who don't do any arthroscopy out there, these arthroscopy towers are really big, and when you combine that with the C-arm or the intraoperative X-ray, it just takes up so much space and makes it difficult. And this just makes it a lot easier. So the camera itself is less than 2 millimeters in diameter, and this is just a close-up of it. And this is the screen that it comes with. So once again, the footprint of being able to do this in the OR is a lot less. Here's a little video of fixing, so essentially, in addition to fixing the ankle, you can't forget about the ligaments there. So this is one where we've already fixed the main connecting ligament between the fibula and the tibia, and there's still some rotational deformity there, so we're going to use those sutures to stabilize that. There's another ligament on the medial side of the ankle called a deltoid ligament, which is often ruptured, and traditional teaching says, well, once you fix the fibula, that should be fine, and that hasn't always panned out. So these are one of these things that you can fix at the same time, and the X-ray on the right is just placing a suture anchor. Can you get this video to play? I just want to see how it plays. If you click on it, or is there a way for me to do it? Nope. Oh, there we go. All right, that's the ligament. It's ruptured. So can we start this video? This is just a case, 16-year-old trampolinist. Apparently this is actually an Olympic event. So she's jumping, and then boom, right there. So you can see on her right ankle is externally rotated, and that causes a fracture. It's not a terrible fracture, but she's a high-level trampolinist, and she wanted to get back to her sport as soon as possible. This is a little stress-free review we did in a CT scan, which shows that the syndesmosis, the connection between the fibula and tibia, really isn't totally right. So this is someone we ended up doing surgery on. And the picture on the right is a piece of cartilage that's essentially flapped off. And can we start the other video on the left? That is the shaver, and I'm pushing it in between the fibula and the tibia intra-articularly, which confirms the fact that it's a syndesmotic injury, or it's an unstable ankle fracture. And this is the case right here. Once again, she had a relatively simple one, so we use these percutaneous clamps to hold everything together. And that's the implant right there. And in terms of indications, I mean, I think you can use this on almost every ankle fracture. And whether or not we should put an arthroscope in there and to check out the inside of the ankle, there are some doctors that think it should be done on everyone. I don't think so. I don't think a 85-year-old needs this. But for me, if it's a teenager or a young adult, or someone super active, or if they have intra-articular fragments seen on a CT scan, I think that's a reasonable patient that you would do this on. In terms of the contraindications, someone who has a really high fibular fracture, like the one on the left. So the longest nail so far that we have is 180 millimeters. So it's got to be more than that. It's got to be shorter than that. And then there are some patients that have this really skinny fibula and very narrow canal on the right. And that one, I thought I can get a nail into, and I just could not get the reamer past it. So it's probably got to be over like a 3 millimeter diameter. In terms of contraindications, there's some other contraindications as relative contraindications, such as a highly comminuted or a fracture that's broken up into a ton of pieces, or for a fracture that already requires a big incision for something else. Usually when there's a fracture in the back of the ankle, I have to make a big incision so I can fix the fibula through that incision. Post-op, this is a busy slide. So the long and short of this one is that these fractures, I used to make patients be off their foot for 6 weeks for pretty much all of these fractures. So now there's definitely data showing you they can walk on it from day one. I don't like doing that because I want the skin to heal. So I'll let most of my patients start walking on this at 2 weeks. And by the time they've reached the 6-week mark, they're full weight bearing, and then we're getting them out of the boot. All right, thank you.
Thanks, man. Okay. That was a great talk. I will say that in taking care of trauma patients, there are some people in our group that take care of a lot of high-level elite athletes and very young patients, but there's also some of us who take care of the elders. And nailing fibulas has completely transformed my practice with regards to being able to manage soft tissues, especially in elderly people, in diabetic patients, in patients with a lot of comorbidities. It's completely changed the way that I take care of ankle fractures, and it's, I think, something that's going to completely take on and become the standard. So if I could have come up here on my knees to beg for forgiveness, I would have. but my knee kind of hurts. So I accidentally changed the order here, and the next talk was supposed to be by one of our senior-most surgeons, who now I have to beg for forgiveness to. She's Dr. Anne Ouellette. She's the director of our hand service. She's the doctor that started and completely built our hand service, and she's really a fantastic, not only a fantastic surgeon, but she always has some incredibly interesting topics to talk about. So without further ado, Dr. Ouellette.
Not to worry. I come from a trauma experience. The universe sends incoming all the time. You have to be prepared to shift. And so I was asked to speak on 4 different topics. So I'm going to really fly through this because it's really an arc of my career. And so now with this cue thing, how do you advance the slides here? The green button. There we go. So first is biomechanics. And biomechanics, for me, was a great way to begin looking at what kind of treatments we were using. And actually, the 2 stimuli for this were Ted Hansen at University of Washington in Seattle, who really began a lot of this open reduction internal fixation because he came back to Seattle with AO techniques from Switzerland back in the 60s. But the other person was Gus Sarmiento, who also began to look at the contribution of soft tissues to fracture fixation. So these folks began me down this journey and interacting with the biomechanical engineers. And so our first thing to look at today is TFCC tears. And that was a big problem back in the 80s and early 90s because we knew that there was something more going on. And you can tell that this is a very complex set of structures here with many different attachments. And it's really, and I did a little video earlier today, much of my understanding of this and discussion of it began in Argentina because we began to go down to Argentina and participate in the orthopedic and hand conferences. I was then able to bring a number of hand people because we had our own research group that we brought down to Argentina and worked with Zeidenberg and Zancolis, et cetera. And it's out of the discussions of TFCC and instability between the ulna and the carpus. It's not just the ulna and the distal radius. It's also the ulna and the carpus. This is a bidirectional joint that I really began to work on this and came up with this model. But it's out of this collaborative experience that this begins to be a solvable problem. So the problem for the TFCC, it's a gliding surface, it's dynamic stability, both pronation and supination. So as you move back and forth, and this arc is responsible for 20% of the upper extremity function. So if you lose it, that's a 20% impairment by workman's comp. It stabilizes the ulnar side of the carpus, and it's a load transfer as well, and it cushions the ulna to the carpal bones. So there's an awful lot of functions here besides just stability. And it has an inherent instability because as you can see, it's sliding up and down in this joint space, and it's got a shallow sigmoid notch to anchor it to. And this is just an example, and I think there's a video, and I don't know quite how to play it from this, that shows you, there it goes, a supination sign. This is actually my research director, Annalena Makowski, but I have one too. So anybody that wants to feel what a TFCC tear feels like, you can come examine my wrist. And so we came up with the modified Herbert sling, and that's also, again, these collaborative things. So I became chief of hand in '92 at UM, and I started a Burkhalter lectureship, and one of my lecturers in the early years was Tim Herbert. We really wanted to talk about scaphoid fractures, but while you're sitting there over a cadaver and looking at all this, we began to discuss ways to stabilize the distal ulna. And he had come up with a way to stabilize one of his implants, but when I heard him speak after hearing the folks in Argentina from Zancoli and Capangi, who had come from France, in addition to listening to Jim Hunter talk about these things, I said, that's it. Tim Herbert has the right idea on this. And so we began to work on how do we make a model of this and how do we study it to demonstrate what it actually does. So this research for us has been going on for 30 years. And our first presentation of it was 1996 back at ASSH. So does disruption of the peripheral TFCC cause ulnar carpal instability? So we looked at 20 fresh frozen specimens with the elbow in 90 degrees and 90 degrees of pronation. And we fixed the carpus and the ulna, and then we cycled it. And we basically picked up on using the Bryan Adams method, which is really to look at the ulna to the radius. And we found that that was not good enough. We needed to make an oblique, so you can see that this is obliquely across the wrist. It is not transversely across it, because that only in that way are you going to pick up the carpal bone instability to the ulna. And this was begun with Chris D. So looking at forces, I won't spend too much time on this, but stiffness is the resistance against a maximal dorsal displacement. So you can see there's this volar translation in the neutral zone. Dorsally you get stiffness resistance, and volarly you get it. And the same in the neutral zone displacement range where joint motion produced the minimum resistance. So the neutral zone is inversely correlated to stiffness. And that's the key. We're looking for stiffness. So if you had stiffness, things were intact. And but post-tear, you start to lose that stiffness. And so a lower stiffness indicates less stability. And so only in the ulnar carpal joint evaluated, distal radial ulnar joint instability is well established, but it's underpowered for the neutral zone and looking at this supination sign. And so when we went and looked at repairing, doing a Herbert sling, doing just a suture repair or a suture repair plus a Herbert sling, we found that we were able to actually improve the stiffness and diminish the ulnar translation. So the percent of ulnar variance and how much it's translating, we definitely improved with the suture repair and the Herbert sling. So the two together will get you distal radial ulnar joint stability as well as ulna to carpus stability. And and we will be coming out with a paper looking at the last 10 years of Herbert sling with the fast fix anchor, which is, you saw a little bit of that inside out on the meniscal repairs. We just borrowed it for the TFCC, and they hold. They hold, and people can go back to their sports and compete at high levels. I actually have 2 records out there with that TFCC repair. One is at the arena in Philadelphia, 52 points scored in a single game by a single player, and that record still stands. And the second one is the highest scoring NHL player in that year, and that was after Herbert sling in that player. And so you can get people back to very high levels and higher than what they were before, because now they have stability, because these things are occurring over a long distance of time. Distal radius fractures, looking at that. So one of the things that we found recently, we wanted to look at fall on an outstretched hand. We wanted to look at what kinds of fractures occurred, what kind of torque was necessary. And so we looked at 8 hands with a perpendicular, 8 with radial deviated, and 8 ulnar deviated hands to see what were the difference in the fracture. And this is the initial question. We found a lot of other answers on the way. So these are some of the fractures that we created. And then we had gotten x-rays and MRIs pre and x-rays and MRIs post. In the post-evaluation, we found that 25 of the 45 wrists, 56%, sustained at least one carpal bone fracture. These are being missed because you don't see them on x-ray. Most of the fractured bone overall were scaphoids with 18 of the 25, but others were 11 lunate, 5 triquetral, 6 capitate, and 3 hamate, which has caused us to rename some of these injuries to ring injuries, but I'm going to go through that in a sec. So, and that's all from the biomechanical lab. So distal radius fractures can be associated with carpal fractures. They're also associated with extension of ligament tears. So looking back in the ligament literature for wrists back into the 60s, into the early 90s, Steve Villegas, 60% of people had TFCC tears. Another 40% had scapholunate interosseous ligament tears. These are all partial. They weren't debilitating, but they're present. And this is looking at cadaver specimens. So we wanted to go and look and say, okay, well, how many of these are linked with the fall on an outstretched wrist? And so we, in going back through all of these MRIs, and we had to go back through them 3 times. So every time you ask a question, you're going to find more answers, that you have to ask more questions. So I just tell you, when you start engaging in research, don't get tired of asking questions, because more are going to come. And one of the things that we found is that you not only got a distal radius fracture, but you can see this goes across the capitate, the hamate, back across the peripheral TFCC. And that is from somebody who had some of this. They had a peripheral TFCC pre, but then you get more post, and now you really get instability across that wrist. And that's another interesting thing. 2 pro tennis players that I have seen later in their career. One of them was in the top 10 male rated players and lost his career after falling on an outstretched wrist. Nobody could find the fractures. Everybody told him, there's nothing wrong, you can go back and play, but he couldn't. And when he finally came into me, somebody said, you know, he should come see you. And when he did, I said, okay, I'm going to tell you what you have before I examine you and before we look at the MRI, because I'm pretty sure I know what happened. And then I'm going to use the exam and the MRI to prove to you what happened. It's not your fault that your career ended. And we went through his exam and the MRI, and sure enough, there was the ring injury. I'd also seen a retired player, but who had been become a teacher and a coach in tennis, and he had fallen in the '74 U.S. Open in Houston and had a similar kind of injury, and that affected the rest of his career, and sure enough, he had a ring injury. And so these are subtle, and you don't see them on the x-ray. You're going to have to get MRIs, and even with the MRIs, even when I just recently diagnosed one in a figure skater, the folks that are following her say, we don't see it. I said, I know you don't see it. Take a look. Take a closer look. It's there. And her exam confirms it. So I will just tell you, have a broader mind about falling on an outstretched wrist. So when you're looking at epidemiology, we've now tagged Annie Weber, who's one of our new attendings down in the Keys, and she's going to be looking at things. So nerve repair. This also is another area of my interest, but difficult to follow, particularly at Jackson, where all these patients were in the drug business. Therefore, not only do they not want to follow up with you, but they didn't give you their right name or phone number. Can't tell you the number of angry fathers of young women who were yelling at us about that ne'er-do-well who we had taken care of and had given us his number. So the bottom line with nerve anatomy, you've got epineurium, intravascular epineurium, you've got endoneurium, Schwann cells, axons, perineurium. All these things play a role in nerve injuries. And so for crushing, penetrating, lacerating, stab injuries, you think of lacerations as a nice clean cut, but really there's a lot of force in that, and it transmits that energy. And severe fractures, both particularly pelvic, humeral, and knee dislocations, gunshot wounds, oncology, iatrogenic nerve injuries. So a lot of different ones. This is a gunshot wound, and this is me showing you decompressing the epineurium and the perineurium around the fascicles in order to decompress that nerve and take the pressure off it and allow the axons to reestablish their blood supply. But this can give you a loss of function, a loss of sensation, pain secondary to intraneural neuromas if you leave that pressure. And so that's another aspect of nerve injuries. Natural healing, if a nerve's transected and not repaired, you're going to get a neuroma. And a neuroma is just a tangle of axons without a bridge to grow across, and so it forms scar tissue. And they can be very painful to the patient as well as disrupting their function. So the nerve injury algorithm is you explore it. If it's contused, you cover it with soft tissue. You know, you can decompress the nerve like I just showed you in a gunshot wound. But if it's transected, you can tag it and then come back in 7 to 10 days to end-to-end repair that nerve. And again, with Jackson, we didn't have time to wait, so we went back in that 7 to 10 days and repaired nerves. You have to bridge the gap and remove permanently the injured part. And so it's always knowing how much of that nerve to remove. So 2 types of direct repair, epineurial or fascicular. Personally, I recommend epineurial. The less you manipulate this nerve, the better it's going to heal. And the goal is to repair without tension. Hanno Malesi told you with brachial plexus repairs, leave a 1 to 2 millimeter gap. And that has actually been confirmed by nerve pruning. Goal is the repair without tension. Tension leads to poor outcomes. So if you put tension on this, and this is also Bjorn Redefining and Goran Lundberg demonstrating this in posterior tibial nerves. If you put those nerves on stretch, you're going to diminish the blood supply, and there is a vasovasorum, so you need to be aware of the internal environment of these nerves. At 2 weeks, a matrix with capillaries and fibroblast-like cells are going to start growing, and mononuclear cells between the nerve endings, and so that's going to start bridging the gap. And so initial injury transects a large portion of nerve, and the nerve is not repaired immediately, so you have these scarred or crushed endings, and that gives you failed primary repairs, which is one of the reasons why George Ormore told you to wait 3 months to really be able to see the neuroma. But even that is not sufficient, it turns out. So nerve conduits have really changed a lot of what we do, and it eliminates the donor site morbidity, so you don't have to take a sural nerve graft. It's off the shelf. There's no secondary surgery to harvest an autograft, and so those are lovely. You can easier match the autografts, but the key is the gap can't be greater than 2.5 centimeters, otherwise the nerve just penciled down and will not grow across that. And you can take nerve wraps in different situations where you've had damaged nerves, and ulnar nerve release in particular, or a flap to stabilize that ulnar nerve, and you know that the muscle and the fibroblasts there lead to a lot of scarring around nerves, so the nerve wrap helps you protect that nerve. If you have a peripheral nerve injury, the axons grow at a rate of 1 millimeter per day, and the nerves need to regrow to the end organ that they stimulate. But it is not a done deal, and I do believe that we're going to find over time that those nerves growing down, you don't have to get them there in 2 years. You just have to get them there. How do we know that? Botulinum toxin. You make new nerve endings, right? You make new, and it occurs. And botulinum toxin you have to re-inject every 3 months. So from Botox, we've learned that muscles will make their acetylcholine receptors again and again and again. You just have to get the nerve there. So even after the target is reached, the nerves will continue to regain function years after the repair. And I've had people with brachial plexus injuries that we repaired come in 10 years later and say, I just wanted to show you what I have. It's not perfect, but it's function, and they are able to use their hand. So histology of gunshot wounds and laceration. This is another area for us to be looking at. And how much of the nerve is actually permanently damaged? And that study, by the way, will get out sometime this next year as well. Nerve regeneration after gunshot wounds only has a 25% success rate. Why? We don't take enough damaged nerve out. Nerve transection after laceration gets a 40% repair, but that's also, we're not taking enough nerve out because there's an awful lot of crush injury that goes along with this. So looking at our longest specimen in our gunshot series was enough nerve taken. We took out 18 millimeters proximal to the transection and 12 millimeters distal because we could see that that was the swollen, injured area, and the biopsy's taken 7 days post-injury. And the most proximal part of the biopsy only has a few myelin ovoids in it, and the most distal degeneration is in full progress. And this is giving you a perspective on it. So when you look at the 18 millimeters from the transection, you're already seeing Wallerian degeneration. And just proximal to the transection, you can see it's all blasted apart. You can see myelin injected into the axons. And just distal to the transection, you can see there's just a bunch of scar. And 12 millimeters distal, you're seeing the Wallerian degeneration. So the axons are intact, but you're seeing everything degrade, and it's going to have to be, reconstituted. And so the problem for us is, did we take enough of the nerve, and did it come back? And unfortunately, an 18-year-old with a gunshot wound is involved in the drug trade. And in Dade County, the death rate, the age at which these people die, back in the 90s and even today, is 22 years. If you engage in the drug trade, you've already signed your death warrant. And so that's part of the problem with what we're dealing with. And you can't get the follow-up to show you what's going to happen with these people. So we also have some other interesting things going on using connective tissue membrane, liquid paste, which really has 79 growth factors, and we have found that to be tremendously helpful in helping nerves repair. Also using electrical pulse generators, but also I'm going to have to talk to Dr. Sporer about some of his ultrasound and looking at that, as well as structured water. And we're going down some other areas. And it turns out that structured water, which is phase 4 water, and it's at an Orthopedic Research Society meeting that I heard this lecture given by Gerald Pollack from the University of Washington. And you already know the 3 phases, from vapor to liquid to ice. But we keep forgetting there's this 4th phase, which is basically jello. And you can pull water and stretch it like taffy. So any of you who have watched the movie The Abyss and see that column of water that comes out and communicates with Elizabeth Mastrantonio, that's phase 4 water. And James Cameron is always ahead of himself and ahead of us. And it's very interesting. But we have begun to look at that in terms of nerves. This is what quantum computing is done through, phase 4 water. And I really do believe we are 95% water, and we're going to find that a lot of this is water. If we can re-energize ourselves, we're going to find that we're going to improve nerve repairs and improve our communication. So the theory across all of this is a traumatic injury to peripheral nerve causes structural damage, and if the damages to the nerve tissue are not removed, you can't get complete healing. So we wanted to develop some detection methods for permanently scarred issues and how much to remove. That's also going to be in the micro CT, but also in ultrasound. What you really want is to be able to get a histologic section of the living without having to kill them to get that histologic section. And we are very close to that. We've been asking for that for 30 years, and we're truly right around the edge of getting these kinds of things. So that's going to tell you how much of that nerve is irretrievably damaged and that you have to cut that out. And that's going to help us develop new technologies and procedures as well as remote detection and removal of scar tissue from permanently injured nerves. So they asked me to talk about skin coverage. And so skin coverage, how on earth did I get into that? Well, hand always was skin grafts. But once I learned how to allow wounds to heal secondarily, I never looked back and I never went back to skin grafting. But there are some things that do require that. So we started using bioengineered skin graft, particularly with epidermolysis bullosa. And so young, active fibroblast and keratinocytes demonstrate persistence of cells in wounds out to about 6 weeks. And it creates a new matrix, fibronectin, vitronectin, proteoglycans, cytokines, and growth factors. So having a skin that is bioengineered and that you take out of a petri dish is amazing what it can do in your wounds. And so the operative technique in epidermolysis bullosa, these are hands that turn into scarred cocoons because every time they touch something, their skin sloughs. They don't have the pegs that hold it to the dermis. And so we started to pull these hands apart and use this skin graft to hold them. And we used Mepitel dressing in a soft bundle. So here's an example of this kind of mitten hand, and then opening it up and putting skin graft across it. And all the patients were able to regain functional use of their hands with no surgical complications. And so we were amazed at this. So doing that for about 5 years, we realized, oh, we could use this for Dupuytren's disease. And so we took it to Dupuytren's. And we started doing fasciectomies. We'd already been doing open macache, but then we started putting the skin graft on the Dupuytren's cases in an effort to kind of break up the DNA of the scarring of them, because this is the palmar fascia that has the fibroblasts, the myofibroblasts in them that scars and pulls everything down. So we started using these to get new skin growth, and it's been pretty amazing what has happened for us. So, and I've had a number of patients that thought everybody did it this way, so they went to somebody else after they'd had this and had the typical Brunner zigzag and realized, oh my gosh, what did I just do? Come back and we redo it with this and get them far better function. So this is basically a fire break technique, stopping progression or recurrence of contractures and resurfacing the fasciectomy in a smaller area. And so that really helps. And so I've quoted a number of other people, but we also have an ongoing study with this, and that will be coming out as well, hopefully in the next year. And so this is a chance to see if you have to be so aggressive and the recurrence and continuing with fasciectomy and dermatofasciectomy. So the outcomes of Dupuytren's disease following surgical and non-surgical treatments, we really want to try and get people out so their hands function and have reduced recurrence. And that's also going to turn out to be blood supply as well. So there's a number of other things in this as well. But the theory was that using 3 modalities, i.e. a bioengineered skin coverage and looking at the recurrence rate, as well as understanding the treatments of Macash with Aplacraft versus Zeoflex versus conservative silicone sheeting, we've added one more arm to that in this past year, which is nitric oxide. That's the active ingredient in beets, increases your oxygen. And as of this last month, we've had 3 patients come back into clinic that started out with very mild Dupuytren's symptoms, but no contractures. We put them on nitric oxide, and they came back with nothing. They don't have any contracture. They don't have any beginning Dupuytren's now. So we've got a lot of arms to this study now to work on. Psychological support. When did I really start going on that? Jackson, in the early 90s. And we decided to look at trauma patients, either orthopedic hand, but multiple trauma and burn patients. And we found that many times, even with just a small injury, people would just fall apart. And why? And in hand, you really need them actively involved with you on your hand therapy unit, as well as with you on rounds, and rehabbing themselves. And if they're not actively engaged, you find you don't achieve what you want with hand cases. So we started to ask the question of why. Why were they disengaging, and what was going on? How could we measure that? And so in looking at this, we looked at maladaptive coping strategies, which are emotional venting, denial, mental and behavioral disengagement, substance abuse, self-blame, a lot of issues going on with these patients. And so looking at the weak to moderate positive associations, we looked at 5 hypothesized coping strategies and the TSC-40 scores. I won't go into all the details of that, but the psychologists among you understand all of that. And but I'll get down to the sound bites for it. So we showed that behavioral disengagement, emotional venting, and self-blame contributed to the injury and related to distress. And these were very correlative for us. And so then with emotional venting, it temporarily reduces stress, but you can't keep doing that long term and move ahead and engage in the injury and what you have to do. And so it's basically, you constantly deflect. So I'm sure all of you have walked up to the bedside, tried to engage the patient on the rehab they need to do, and they're deflecting you into all the other problems they have. Behavioral disengagement, they just won't even face it. So it's effective in acute settings where you just have to kind of relax and meditate and let the team take care of you, but it leads to increased stress because you're not engaged in being part of the solution. Self-blame, I caused this, or better yet, they also blame others, and we all have to stop with the blame game because again, it's not going to help you move forward. So the intervention, what we came to is helping individuals shift from a maladaptive coping strategy to one of active problem solving, seeking social support, emotional regulation, helping them kind of self-meditate and calm themselves down and reframing the self-blame. And the example that I'll give you is going around on rounds with Kent Burnett, who had just moved to the University of Miami from University of Wisconsin. And he lived across the street from me, so I was like, oh my gosh, God gave me a gift. I need a psychologist. So I brought him on rounds with me with Jackson. And one of the patients that we saw was somebody who was a drug abuser, had an abscess on the back of his left hand, and that abscess was going to lead into the the muscles, the tendons, as well as the metacarpophalangeal joints. And once that starts to happen, you start to lose that finger. And we knew that without psychology intervention, we actually had a higher amputation rate than when we did have a psychologist on the service helping these patients. And we'd already done that study. So I already knew I needed a psychologist, but I needed to prove what we were doing. So with this patient, I start moving his hand because he's not engaged, he's very passive, he's angry. Angry he's got to be with us. And of course, any drug abuser and somebody living on the street is already worried that we're going to report them. That they're going to somehow get interventions from the police, which we never did. But no matter, he doesn't know that. And I start moving his hand saying, "Sir, you've got to move your hand." And I'm moving his hand and he comes up to punch me. And I have karate, so I batted his hand away. And I keep moving his hand. And he comes up again, and I bat it away. And he comes up again, and I bat it away, and I look at him, "Sir, you live on the streets. No judgment on my part. Any of us could land in this spot, and nobody knows when they're going to be here. But I need you to move your hand, because if you're on the streets and you're trying to protect yourself with this left hand, and you're leading with your PIP joints, not your MP joints, you're in trouble. Let me help you." And at that point, he just calmed down. We got the motion. Good. And then we went out in the hallway, and Kent Burnett just broke out laughing, going, "What on earth was that?" And I said, "I needed to help this man live his life. No judgment on my part. I need to protect his hand so he doesn't get an amputation. I already knew that piece of data. He didn't, and you don't, but you're going to help me figure out why I can figure out what's going on psychologically, and then how can I help him?" And at that, this project was born that day. and of course, our gentleman went on to do FIND. So it's learning how to help people and validating their life and what's going on. So did we ever go back, once we define these, and this paper's been quoted all over the place now in trauma literature and the hand, et cetera, as well as other places, because I did it with psychology, and it was published in a psychological journal. But we need now to define what are the tools that we have to give these patients to help them. So that's our next avenue of research. And fortunately, being linked with FIU and psychology in a PsyD program, I'm hoping that's going to happen again. And so thank you very much. Here's all the intersections.
That was a fantastic talk with a lot of incredible information and stuff that we don't really hear very often, which is insightful. So, one of the things that I think is missing in almost every single orthopedic practice around the country is a joint preservation specialist. It's a very sort of niche topic, but incredibly, incredibly valuable to have. And you really only find a couple of doctors here and there around the world, really around the country, in some of the biggest centers or some of the most specialized centers, and we're fortunate to have one. So I'm introducing to you Dr. James Ross.
Thank you. Okay, thank you very much for having me. Appreciate the opportunity to talk about this topic, which is very near and dear to me, that I have a passion for, and that's joint preservation surgery. So you heard earlier about joint replacements and how successful they can be, but how can we potentially avoid them? So I think to talk about this, it can be a very broad topic, but we'll focus on the knee. And most of the times when a patient comes into the office with knee pain, oftentimes they'll be diagnosed with arthritis, and the solution after failing non-operative treatment is a knee replacement. But what happens when a patient comes into the office with knee pain like this? So I think in order to really talk about this topic, it's important to really understand the anatomy of the knee. So I'll kind of breeze through this. So the knee has the femoral condyles, which you see above, the tibial plateau down below, and on the ends of these bones, there's articular cartilage, which is a hyaline cartilage. It's what you're born with, and it's the white shiny stuff you see on the ends of chicken bones, which is what I tell my patients. And that smooth surface on both sides of the joint allow for your knee or any joint in your body to move friction-free. When there's damage to that cartilage, that can cause pain and dysfunction. And then the other structure that's unique within the knee that can be problematic is the meniscus, which are those C-shaped fibrocartilage type structures in between the two, in between the femur and the tibia, and then finally the ligaments. So if we have a 30-year-old patient who presents to the office with knee pain and they have normal joint space, well, what's in between those joint spaces? And that's what we talked about. So the blue would be represented by the articular cartilage of the femur, the green being the articular cartilage of the tibia, and then the pink structure being the meniscus in between. And that's why we have a joint space on X-ray, because those structures are not able to be seen on X-ray. So it's not until we are able to obtain an MRI until we can see what's going on in that space. And on the MRI image on the right, what you can see on those arrowheads is that there's loss of the articular cartilage. Is there a pointer? No pointer. So there's a loss of the articular cartilage in that space. So if we take that patient to surgery, this is an arthroscopic image. The image on the left is a portion of the patient's femur where the articular cartilage is normal, but as we flex the patient's knee, what we can see is that there's a pothole in that cartilage, which is this patient's cartilage defect. So how can we treat this? This is a very focal area. A knee replacement would be very extreme, and this patient's having pain, dysfunction, swelling. So treatment in the past consisted mostly of chondroplasty, which is essentially kind of cleaning up the borders of the cartilage that's unstable. Eventually that morphed to something called microfracture, where you can drill holes in the bone, hoping that the stem cells and growth factors that come out of the bone marrow can create a clot and eventually form some sort of a cartilage, but that cartilage is called fibrocartilage, which is not as durable as the articular cartilage that you're born with. So then fast forward, there's other things that you can do. De novo, which is a fetal type cartilage, biocartilage, which are other types of options that can produce more hyaline-like cartilage, but still is not perfect. And then finally, OATS and Carticel or ACI, those are more procedures that are trying to aim towards reestablishing real hyaline cartilage. So this is that patient's knee. So once we open up the knee, you can see where there's that focal defect on his medial femoral condyle. So how can we treat this? One option is something called OATS. OATS stands for osteochondral auto or allograft transfer system. So in this patient, because of the size, we're not able to move around native cartilage from within his knee, but rather we can use cadaver cartilage. So what we do is we actually take this patient's MRI scan and we send it off to a graft company. My preferred graft company I like to use is called Joint Restorations Foundation, which is based out of Colorado. And they take serial measurements on the patient's MRIs, looking at the condyle width, the tibial width, etc. And then when a patient who is a donor passes away, they harvest the patient's knee and they make respective measurements on that. And once there's a size that's within a certain percentage of a match, that knee is harvested and offered to the surgeon to proceed with a surgery. And you have a couple weeks to use it because the cartilage are living cells, so you want to get to implant that as soon as possible so that it is able to be placed back into a synovial fluid where it will continue to have its nourishment and proceed. So this is just an example of what we get. We actually get a picture of it, we get the measurements of the donor, and we decide if we want to proceed with surgery. So that's what I like. And in this patient, it's a 20-year-old male, so a nice, young, healthy cartilage. So what we do in surgery, this is that exact same patient. So we bore out a circular hole or a socket that encompasses the entire defect. We take the defect out, and then we create a recipient or a donor plug that matches that exact recipient socket and press fit it into place. And that is, again, living cells, usually 70 to 90% viability, and patients will go on with clinical success. Now, a lot of these patients have underlying mechanical reasons for why these cartilage defects have occurred. So in this patient, if we get long leg standing alignment films and we look at the weight-bearing axis from the center of their hip all the way down to the center of the ankle, what you can see is that their weight-bearing axis travels through that compartment where their cartilage defect is. And what we know from research is that if you don't change their alignment and take the weight-bearing axis out of that compartment, the longevity of that cartilage transplant is not going to be as good. So in all of these patients that have cartilage defects with weight-bearing mechanical axis problems, I like to template a correction such as this, and then we can perform the tibial osteotomy and shift that patient's weight-bearing axis away from the compartment where the cartilage was transplanted. So how do these patients do? This is probably one of the best studies that's out there. This is a systematic review that encompasses 19 different studies, so over 1,000 patients. And if you look at the mean survival of these cartilage transplants, these are the allograft cartilage transplants, at 5 years, nearly 90% survival, 10 years, 80% survival, 15, 72%, and even 20 years, 67% of these patients continue to have their native knee and have not progressed to a total knee arthroplasty. So pretty good success. So what are other options that are out there? Treatment options are constantly evolving. New things are coming to the market. But in a patient such as this, where the bone is actually okay, is there anything that we can do to replace the cartilage alone? So going back to our treatment options, if we're looking towards restoration, we've already talked about the osteochondral auto and allografts, but what about autologous chondrocyte implantation? So what is that? So autologous chondrocyte implantation, or ACI, was primarily started in Europe before it made its way to the United States. And what that is patient's cartilage, a patient undergoes a biopsy of their cartilage. And those cartilage cells are broken down in the lab, and they're actually cultured up in order to multiply the numbers of chondrocytes, and then they can be reimplanted into the patient at a second surgery. So the first report of ACI that was done was in 1994. The FDA approved this in 1997 and started to gain popularity. The problem is that that original surgery, the first generation surgery, was very tedious because at the initial time you had to take a small thin layer of the bone called the periosteum and sew it into the cartilage and then inject the solution of the cartilage cells underneath, making sure it was watertight and not able to leak. So it was potentially a 2 to 3 hour procedure depending on how many cartilage defects were needed to be treated. But it was very successful, but many surgeons just didn't want to go down the route of taking the time and really being invested in that surgery. So fast forward to what's available today is something called the matrix autologous chondrocyte implantation, which is a lot more technically easier. So looking at this, it really involves 3 steps. First is looking arthroscopically at the defect size and obtaining that cartilage biopsy. The cartilage is then sent off to the lab where those cartilage cells or chondrocytes are multiplied and eventually seeded onto a membrane. And then the step 3, which is the second surgery, is implantation of that membrane. So this is step 1, so defect assessment and cartilage biopsy. What do we do? So during the time of the arthroscopy, we examine the defect or defects, and we measure the size of the defects, whether or not they're contained or uncontained, meaning if there's a healthy border of cartilage around it, and determine if there's any underlying bone loss or softening of the bone. Once the cartilage defects are evaluated, sized, and recorded, then we go ahead and harvest the biopsy. So this is what it looks like. So I prefer to use a small ring curette, and what I'm doing here is on the intercondylar notch, which is typically not a weight-bearing portion of the joint, we're able to harvest 2 individual tic-tac size cartilage biopsies. And it's important that we really take a very thick area of the biopsy that includes the bone, because the cartilage cells that are the ones that are able to propagate and grow up are the ones that are deep and really adherent to the bone. So that's what they like to see. So that's the process. So after we looked at the defects and obtained the biopsies, those are sent off to a lab, which is in Boston. The cartilage is transported in that solution in the upper right, in that purple or that red or pink solution. We fill out the form and the documentation, and off it goes to Vericel. So in the lab, this is what they do. So they multiply the cells, and then they create this membrane, which you see in the lower left. And this membrane is a dual-sided membrane, which is why it works so well. So what you're seeing on the lower left is the rough side facing you and the shiny side, which they're flipping over. So the smooth surface, or the dual-sided membrane, that contains dense collagen fibers that stop the cells from moving in that direction. And that's the side that's eventually going to face the joint so that the cells don't go into the joint or the joint fluid. Whereas the rough surface are where there's all the collagen fibers, where the chondrocytes are actually adhered to that. And those chondrocytes or cartilage cells are attached via these cytoplasmic projections, which you can see on the lower right. That's an electron microscopic image of those cells adherent to all the cartilage fiber, or those the collagen fibers. So fast forward to the second surgery. So this is currently an open surgery, although there's now an arthroscopic technique was recently released. but the defect is prepared. So we removed all of the scar cartilage or fibrocartilage and really create a nice healthy border of the patient's articular cartilage. And then we use some sort of a template such as sterile aluminum foil to create a size match, and then that foil is used as a template to cut out the appropriate sized membrane in order to fill that defect. So this is just a schematic. Once that membrane is cut to your choice, you put down fibrin glue and then eventually place the membrane into the defect, hold it with digital pressure. I like to secure the membrane with some 6-0 vicryl sutures, some really small vicryl sutures, and really just let it sit there for about 8 minutes while the fibrin glue adheres it to the underlying subchondral bone. So this is a patient example of mine. This is on the backside of the patella. You can see the upper left. That's after I've removed all of the patient's unhealthy cartilage down to the subchondral bone. And you don't want to be too aggressive and get beyond that subchondral bone, because the way I think of it is the cartilage is the house and the bone is the foundation. You got to make sure you have a really good, stable foundation in order to build a house. If you don't have a foundation, eventually the house will break down. So that's the foil template. The foil template is eventually used on the membrane to cut out the appropriate sized membrane, which you see on my glove on the middle bottom, and then after that membrane is implanted into place. So what happens? What's the science? So the patient is held immobile for 48 hours because that's the amount of time that's needed for those cells to migrate off of those collagen fibers and adhere to the subchondral bone. And once they adhere to the subchondral bone, after several months, these cells and chondrocytes are programmed to eventually synthesize all of the matrix proteins that are normally found in hyaline cartilage. And by motion between the other side of the joint, for instance, like the patella on the femoral trochlea, it keeps the chondrocytes from creating too much cartilage where it overgrows. So the match of the two sides of the joint really helps to keep it in check so that you don't get overgrowing beyond the borders of the cartilage. So how do these patients do? The best evidence that we have is within Europe, because they've been doing this the longest. The FDA kind of takes a while to adopt things, but this was a randomized control trial, the SUMMIT trial, which is really what prompted the FDA to approve the use in the US. And they had 144 patients using the MACI implant, 72 per group, and they were randomized to the MACI procedure versus the microfracture, which is the older type of procedure, just drilling in the bones. And what they looked at was at 2 years, the KOOS score, which is a clinical outcome score. They did MRIs, second look arthroscopies, and even biopsies. And this is what they found as far as the clinical outcomes. So the baselines were essentially the same between the two groups, but at 2 years, the MACI, or the autologous chondrocyte implantation, superiorly outperformed the microfracture groups in both pain and function. And then they recently extended this study out to 5 years, and it shows that they maintain these outcomes to year 5. But again, it's important to understand the environment, because without correcting any underlying predisposing factors for why these cartilage defects are happening, patients won't have good outcomes unless you address those. So again, alignment. So this is a patient example that I had that had a very large mediofemoral condyle defect that was cartilage only, didn't involve the bone. So I performed the matrix autologous chondrocyte implantation, and then did a tibial osteotomy in order to realign his knee. And actually now he's 7 years out, and he came back to me to do the other side. And then finally, what about the meniscus? Meniscus integrity is key. Many patients who have had prior arthroscopy and perhaps a meniscus tear where the meniscus was removed, several years later down the road, they may start developing pain again due to the cartilage loss. And unless we treat the meniscus insufficiency, any sort of cartilage treatment won't be successful. So what could we do for a patient like this who has their anterior horn of their meniscus okay in the black triangle, but then they're missing their posterior horn, which is outlined in red, and there's nothing there? Well, we can do the same thing. We can do meniscus transplants. So we can actually get a cartilage transplant or a meniscus transplant from a cadaver that's, again, size matched. What I prefer to do in these patients is I trim down the bone so you get 2 individual bone plugs, which you saw in that image, and then we create recipient sockets on the tibia. So this can be done all arthroscopically. So So this is the posterior horn or root of the medial meniscus. We drill a socket that's eventually going to receive that bony plug. And then this is the anterior root attachment for the medial meniscus as well. And again, we're creating another socket so that the meniscus is going to be able to be anchored in at these root attachments and get bone-to-bone healing at its root insertion, which has much more predictable healing than soft tissue to bone. So once those sutures and sockets are placed, here you can see I'm shuttling in this meniscus graft. So that's the posterior horn of the medial meniscus with that bony socket that's being pushed back in towards the recipient. And then we just kind of pull on the sutures and it eventually docks it right into the bone. And then same thing, here's the anterior socket, anterior root, again pulled into the bone. And then once that those sutures are tied on the tibia, you're left with this meniscus that's in between the femoral condyle and the tibia. And then it's just a matter of putting sutures all the way across the entirety of the meniscus to seal it, to secure it to the capsule, which is where hopefully you're going to be getting the patient's blood supply into the periphery of this meniscus in order to heal it in place. And again, now you're restoring the meniscus function in a patient who has still well-preserved cartilage, which if left alone without a meniscus would eventually lead to complete compartment cartilage deterioration and perhaps an eventual partial or full knee replacement. So in conclusion, joint preservation surgery in the appropriate indicated patients has very reliable outcomes for pain and function. There's a rapid evolution of techniques and treatments, and fortunately these are being followed by well-performed investigations, so lots to come in the future. Thank you for having me.
Okay, so I want to thank all of my colleagues who have come up and given amazing talks. I want to respect your guys' lunch break, so I have a talk to give. I think that I can kind of go through it with some expedience and with some efficiency so we can be able to still have some Q&A at the end of the session. So really, the concept that I'm going to present to you is really a simple one, but one that I think is often overlooked. And like I've mentioned a little bit earlier, some of us tend to have a patient population, especially in Miami, which may skew towards what people consider elderly kind of around the country and even around the world, but we have a really active elderly population, and I think that we need to rethink the paradigm of how to treat these patients. So starting off basically with just the concept of fragility fractures, it was estimated that there's 2 million osteoporosis-related fractures in the United States alone in 2005, and without belaboring the point, it's estimated that by as early as next year, this will have grown by 50% or more. The lifetime risk of fragility fracture, for those who are not aware how high it is, it can be as high as 50% in women and 25% in men. The most common when people think of fragility fractures and osteoporosis-related fractures, people think of hip fractures. And this is really where the majority of the literature has come out over the last 30, 40 years with regards to management of hip fractures. And this is kind of where our paradigm sits and where I think it should be extended further to other fragility fractures that I think can actually result in very similar lack of mobility and poor functional outcomes if not treated appropriately. So there's upwards of 300,000 hip fractures in the United States alone. It's estimated that there's going to be 500,000 by 2040. And these, as I'm sure most people in the audience know, result in significant decline in functional capacity, mobility, and independence. So Dr. Zuckerman up at NYU published what's probably the seminal article on how we used to treat hip fractures, but there was no significant papers out there that would prove what was already suspected, which is patients who break their hip do very poorly. And they published that the one-year mortality, this was back in 1995, the one-year mortality was 80% without surgery. And even with surgery, it was upwards of 20%. And in some series since then, has been shown to be 30%. The most devastating complications were, no surprise, due to prolonged recumbency. Pneumonias, venous thromboembolic events, cardiovascular events, decubiti, and complications associated with muscle weakness and atrophy. So basically from there, everyone kind of decided and agreed, listen, these patients need to move. And being in bed is the worst thing that you can possibly do to anybody, much less somebody who is elderly. And in our patient population, the worst is the active elderly, because they're so used to having a point of balance in their lives where they're moving and they're active, but one hit can ruin all of it. So essentially, this is where the paradigm started of you must try to do as close as possible to 24 to 48 hours from presentation, the operation to fix these patients. And the whole point is to restore length, alignment, and rotation, restore anatomy, reduce and compress the fracture, and hold it in a stable fashion so that they can weight bear early. And the goal for all of these patients is immediate weight bearing and immediate rehabilitation. This data has been reproduced over and over and over. Even just as an example, this paper that came out almost 30 years after the Zuckerman article, again showing that surgery within 24 to 48 hours is preferable because delayed surgery was associated with an increased risk of 30-day mortality and other complications. Again, pulmonary embolism, myocardial infarction, pneumonia, and all of these remain significant, not just at 90 days, but at even 1 year later. So this begged the question, we do this for hip fractures. We understand that when a patient has a broken femur or a broken hip, they need to go to the operating room as quickly as possible so that we can stabilize them and get them walking. But not only are hip fractures a common fracture, but we have a whole other litany of osteoporosis related, or what we call fragility fractures, that occur all over the body. And are we ignoring these patients? Are we not being aggressive enough in our treatment of the patients in order to be able to get them up and moving? So just a couple of very, very common fractures that we see in active elderly populations here in South Florida are intra-articular distal femur fractures, proximal humerus fractures, and proximal tibia fractures. So the standard of care, I think, or the community standard, has generally been for periarticular fractures of the ones that I was just presenting, is open reduction and internal fixation with plates and screws. These are load-bearing implants. What that means is that essentially when you're bridging a fracture, the plate and the screw bears the weight of the body as you weight bear, rather than a load-sharing implant, which is an implant that actually shares the load along with the bone, which I'll discuss in a second. And so because of that, traditionally this required non-weight bearing restrictions. We would put a plate and screws, a bridge plate, along a distal femur, and then tell a 75-year-old lady, don't walk on that leg, but you can hop on the other leg and use your walker and kind of jump around. There's not a patient on earth of that type that's going to be able to do that. So that results in, I think, a lot of decreased functional outcomes where I think we can do better. So why don't we extend those strategies out to all these other fractures? And rather than this slide, which shows the standard sort of treatment for these fractures, which was open reduction and internal fixation with plates and screws, maybe we can do better. The treatment for these fracture patterns was plates and screws alone, simply because in the periarticular segment or around the joint, we would be able to have many more points of fixation close to the articular surface in order to be able to reduce and compress the fractures at the articular surface, where an intramedullary nail wouldn't be able to afford us enough points of fixation. However, this is a load-bearing device, like I mentioned before, so the weight is transferred from the bone to the plate, and therefore we can't have patients walking on it because of the fact that there would be a high failure rate of this fixation before any healing would take place. And now, so intramedullary nailing is very popular, but traditionally this was reserved for metadiaphyseal or diaphyseal fractures, fractures close to the joint but not too close to the joint, because we didn't have as many points of fixation to be able to hold the joint in place as patients would walk. So a lot of these patients would be able to weight bear early, but there was a whole other set of patients that we weren't able to do this for. So in 2019, this is probably the first big paper in a big journal that came out that really pushed for the thought behind a dual fixation strategy. This combines intramedullary nailing with locked bridge plating in one procedure, and you can take advantage of both plating and nailing. Improve fixation of the intra-articular fracture with increased points of fixation, but also taking advantage of the intramedullary fixation with stability and load sharing to be able to weight bear the person early. So Liparachi and Yoon basically concluded that combining intramedullary nailing and bridge plating can improve the stability of fixation, allowing for a more aggressive mobilization postoperatively. So for example, this is a 65-year-old male. He's a community ambulator. He's an active, healthy person who can very easily become a very inactive or a very sedentary person because of a major injury. He's got a distal femur fracture with significant metaphyseal comminution, intra-articular extension, and comminution. There's a little bit of a hiccup there in which he had a prior femoral shaft fracture in the past, but that was something that we were able to deal with in the operating room. In this sort of a situation, intramedullary nailing alone would have provided insufficient fixation because of the intra-articular comminution, the amount of fracture, let's say, at the articular surface. There's not enough fixation with an intramedullary nail alone. And then with a plate, if we were to use a plate, we'd be able to reconstruct the entire joint and then restore length, alignment, and rotation, but they can't start weight bearing early. So in this sort of a situation, the technique really involves using an extramedullary fixation, using a plate and screws in a submuscular fashion with a small incision close to the joint, placing the plate along the bone, underneath the muscle, above the periosteum, and temporarily fixing the bone with length, alignment, and rotation restored before inserting an intramedullary nail. Once the intramedullary nail is inserted and there's final fixation, you go back to the plate and finish the fixation proximal and distal to the fracture. So this is a combined nail plate technique. There's improved fixation over intramedullary nailing alone, but improved stability over plating alone. And this patient would start immediately weight bearing from day one and presumably had a much improved outcome compared to either technique by themselves. Here's another example, similar sort of situation. She's a 76-year-old female. She's a community ambulator but uses a walker. She has severe osteoporosis. She's had prior fragility fractures in the past that have needed to be fixed surgically. And I think relegating this patient to a plate and screws and telling the patient, go ahead and walk on your other leg or don't walk at all is going to result in a very, very poor outcome. So again, submuscular plating after restoration of length, alignment, and rotation in order to be able to include intramedullary fixation and then go back and finish the fixation on the plate. There are technical challenges with dual fixation, most commonly because of the fact that you're using two different fixation techniques. So you have to be careful not to, for example, use too many screws on the plate in order to create too much of a stiff construct, because that could result in non-union. Additionally, being able to plan for the placement of your implants after placing one implant in order to be able to insert the second implant and back and forth. So the last thing that I'll mention as we move it along pretty quickly is reverse shoulder replacement. Now, one of the other things that we really need to think about is not just in the lower extremity. The reverse shoulder replacement is not new, but has become a much more modern implant as of late and is used much more in the treatment of fractures because after the initial Grammont designs where there was a 155-degree neck shaft angle and the use of medialization of the center of rotation in order to create a more effective lever arm of the deltoid, there was noted to be significant complications, including notching of the scapula and problems with tuberosity healing, problems with acromial stress fractures because of the increased tension, because having a 155-degree neck shaft angle would cause an overall lengthening of the construct. So in the about 10 years ago or so, papers were coming out showing a redesigned reverse shoulder replacement where we would take that entire medialized construct and have a medialized center of rotation, but lateralizing all of it together, right? So the relationships would all stay the same, but they were all lateralized in order to be able to have a more anatomic neck shaft angle. And that changed, I think, in my opinion, the entire concept of how to place these implants and how to be able to treat patients with things like fractures where there are significant other challenges like significant amounts of bone loss and significant tuberosity fractures, glenoid fractures, and more. So because we have much more stable implants with less complications, they became much more in vogue to be able to treat fractures with them. And as a result, there is no lack of data, no lack of papers that have been published showing that it is not only a viable treatment, reverse shoulder replacement for 3- and 4-part fractures, but in fact actually probably a preferred treatment in many cases. In my practice, essentially with very, very few exceptions, it's completely replaced hemiarthroplasty. And the most important thing about this slide is the bottom. I use reverse shoulder replacement to treat fractures in patients who depend on their arm for mobilization. So for example, this is a patient which just looking at an x-ray is not enough. She's a 79-year-old female, but she's a household ambulator with a walker. She's able to help herself get out of a chair, walk to the bathroom, move. This is not a patient that needs to be hoisted by her family from bed to a chair, which is a very, very different patient. It's a patient that you want to preserve that mobility because the second that mobility goes away, not only is it a burden to the patient, it's a burden to the family, and it results in rapid deterioration of the patient. By x-ray alone or even by these CT cuts, you would think, this could be a fracture that could be treated non-operatively, right? You could treat a patient like this, let's say they're in their 50s non-surgically, and they'd probably do quite well. You may even think, some limited internal fixation with a plate and screws in order to reduce the greater tuberosity to avoid impingement. But this isn't that kind of patient. This is a patient who needs to be treated practically like a hip fracture, in the sense that she's not going to move if she's not able to use her arms to be able to get herself out of a chair, get herself up on a walker, pull herself up and out of bed. And so I would challenge those who really use reverse shoulder replacement but haven't tried yet, use the technique of a well-seated press-fit reverse shoulder replacement with good tuberosity fixation, and do not limit the patient's mobility at all. Weight bearing is tolerated, immediate mobilization, use of their arm for all transfers, walker use, and anything else that they want to do, and they actually do great. So I know I went through it really quickly and I was talking real fast, but we're going to have a Q&A session. I really wanted to preserve that and then still be able to send you guys out for lunch. So I think this is something that needs to be thought of in a more holistic way for the entire body, not just hip fractures and not just femur fractures. And I think Liberace and Yoon, in that same paper that I quoted earlier, said it best when they said, with the early population staying healthier and more active and living longer, the low energy fragility fracture is increasing in incidence. With morbidity and mortality similar to that of the hip fracture population, the goals in operative treatment require urgent operative fixation to allow for early mobilization. And that's everything. Thank you. And with that, I'll invite anyone who's here who gave talks to come up and do some panel discussion and some Q&A. Okay, so thanks very much for your talks, guys. That was pretty fascinating, actually. Does anybody have any questions? Rather than doing any discussion, we should just get right to questions. And also, if there's any questions based on any of the other talks, we'd be happy to try to answer them for you or even get the information for you. One thing I didn't mention is I really like these sorts of symposia because I think that they really provide an opportunity to build bridges and continue communication. I hope that you guys have all of our contact information, and one thing I think that we all love to do is discuss cases and talk about technologies and resources that are available. And so I personally would always be happy to do that. Yes, sir.
Okay, so my question is for you, sir. Regarding vitamin D serum levels in elderly patients, does supplementing vitamin D and K2 reduce fragility fractures?
So there's a lot more that goes into the reduction of fragility fractures than vitamin D alone, but vitamin D is a very, very big part of the equation. It's a whole other talk to give to you guys, which I would love to do at some point, regarding the treatment of fragility fractures, the medical workup and treatment, which we do here actually at our osteoporosis, our bone health and osteoporosis clinic. One thing is being able to measure and be able to follow a patient's bone density over time. And in patients who have fragility fractures or who have evidence of prior fracture or who are at high risk, we actually get them annually rather than every 2 years, which is the standard for screening. But vitamin D is probably the most studied of all of the other elements, such as zinc, magnesium, NTX levels, and every other thing under the sun that we check. For the most part, what I began to notice when I first started my practice in Miami is that paradoxically, everyone has the sun accessible to them 350 days a year, and yet almost everybody that I checked was low in vitamin D. I definitely think that that's one of the big components. We supplement practically everybody who comes in with a fragility fracture, even before beginning a formal workup and treatment algorithm. So I think your point is very well taken in that we basically supplement vitamin D in almost everybody who has a fragility fracture from the get-go. Yeah, so I mean, it's I think that our lab says normal is like 30 to 90, but we try to keep it on absolute highest level possible. There are multiple papers out there over several decades that have shown that hypervitaminosis D may or may not even exist. And if it does, there don't really seem to be any known complications until you start getting into the many thousands, right? So I pretty much put everybody on 50,000 units of vitamin D weekly for the first 6 weeks or so, and then either 1,000 or 1,500 daily for the foreseeable future, until they stop seeing me, and then God knows what they do. Any other questions? Anyone else have anything, or are the stomachs rumbling way too much? Yes, sir.
team says I project well.
They're talking about your beautiful face.
Yeah.
It projects very well.
Or maybe I've grown. So I think the most difficult part, and anybody that's non-ortho, trying to get a patient over here and dealing with trying to get a patient over to us, what are the, in each one of your sides, what would be the minimum that you would need in order to try to evaluate a case and be able to look at it? Obviously, we're using Ambra Health. We used to be DICOM Grid, so if anybody is using Ambra Health too, that works with us. We share imaging. Everything has changed since I started in 2011, and we all have more gray hairs than before.
Yeah, we do.
But what would something you would like to see that makes your life easier? I mean, sometimes as a medical director, Dr. Hakim and I sometimes have to go to our doctors and say, this is what we have. This is all I can share, and then they try to do the best they can. But sometimes the more information, the better it is. So can you share with us, each one of you, what would you like to do before a patient comes here? Or sometimes we have patients that say, I want it all done here. So
Yeah. I was about to say that it's definitely going to be different, everyone that you ask in our group, because what we do is different and what we're trying to look forward to treat is different. For me, it tends to be pretty easy. I mean, just basic plain x-rays can tell a large portion of the story in a lot of situations. Basically any fractures or any post-traumatic malalignment, post-traumatic deformity, post-traumatic non-unions and infections. A lot of a large percentage of what I need to know is happening can be seen on plain x-rays. A lot of times for me, when I'm getting advanced imaging, it's more confirmatory in nature, or for more preoperative planning sort of stuff, or maybe even more esoteric things that nobody else would be looking at other than the one who's going to be doing the treatment. You know, it's always a challenge to be able to share information, unfortunately, which seems crazy to say in, you know, almost 2025, when people are sharing, you know, everything from, you know, emails and pictures on social media to like cryptocurrency, right? I mean, everyone can share a Bitcoin, but we can't share some X-rays and an MRI. But I think that that for me, it's really just almost even just a set of plain X-rays would be great.
I think, you know, in sports medicine, we order a lot of MRIs.
He's very different.
Yeah, we order a lot of advanced imaging, but I mean, I try to make it as easy as possible. You know, I order very specific weight-bearing X-rays for my knees or hips, you know, so I just need a motivated patient. That's really about it, because I'll do my own X-ray imaging and then do my exam to really guide if advanced imaging is necessary. But there's really not much, you know, what I tell most of the people in the community, primary care physicians, is just like, send it to me, let me kind of send it to Dr. Jordan or Dr. Ouellette, because I know where this patient really is going to get the best benefit. But a motivated patient's really all I'm looking for. You know,
Also, I think one of the things that we need is communication of expectations, because I very frequently what I'll need is a patient who has the flexibility to be able to stay to do certain things and certain studies that I may need based on what I see once I see them, right, and once I examine them. So I kind of need a patient that is willing to be able to stay for whatever duration of time that imaging or whatever studies may need to take. And then also a patient who is willing to accept the fact that this may be something that needs a workup, needs the studies done, and then even if we determine then and there that surgery is the best option, there's going to be a certain level of planning that needs to be done for some of these things. I mean, they need to be patient matched a lot of times, measured. We need to be able to bring in graphs, bring in 3D printed. I mean, I could do an entire talk on the 3D printed cutting blocks that we use for total knee replacement and for shoulder replacement. So this may be something that you got to be able to come in to be able to have a certain amount of workup done, and then you might need to go and then come back, you know, or unless they want to stay the whole time. But I think there's just certain expectations of how the process works that might need to be communicated as well as possible.
Dr. Ouellette?
For me, it ends up being the imaging and the MRIs coming from all of Latin America and the Caribbean, for the most part, are adequate. For what we have. So I can evaluate those things. Nerve conductions are also very good across the board, so that if I get that information ahead of time, I can then make an assessment, talking to the patient by telemedicine, what other things are we going to wish to have? Do we want a repeat nerve test with an ultrasound, et cetera, you know, whatever that's going to be. And so that the beauty for me would be to be able to set that up so that the patient arrives, gets all those tests, then sees me, then we put the whole story together to figure out if there's anything else more that we need, because I really try and minimize them having to travel back and forth to their country. And we've done this particularly with Europe as well. Very good studies coming out of Europe, so no problem in evaluating those people and then putting the story together for them.
Great point.
Rehab component's so huge in everything you all do. Can we talk a little bit about how rehab has changed to what it was before and to what's going on now and everything your team does?
What do you guys think?
Yeah, I think we're going to much faster rehab protocols. Along with weight bearing is tolerated for me. A lot of times, in the past, ACLs were put in a cast for weeks and weeks. Now, we get them moving right away. We get them walking, post-op, in the PACU. So the therapists see our patients in the PACU. They give them exercise to do at home. The first post-op visit where we take out their stitches, we start them on a rehab protocol, and every patient gets what the outlook is going to be for the next 6-8 months, so they know really what to expect and what goals they really need to meet, so the patients can see themselves progressing.
And I think there has been, every year we get more and more towards outpatient or patient-centric rehabilitation and less towards inpatient, long-term rehabilitation at facilities, because really that ends up, in my patient population, that ends up actually backfiring a lot of times. It ends up being very inefficient. I tell my patients, I'm going to want you to get up and walk and move. And being at a rehab facility where, yes, you may get a couple of hours of therapy as an inpatient, but all the other time you almost have too much help around. And we have to resist you not getting up to go to the bathroom, or not getting up to get your own food, and not getting up to, we have to resist the temptation of everyone around you to be doing that for you, and you have to be getting up and doing that. That's part of the therapy, that's part of the rehab. The rehab is 24 hours a day, because we don't just do therapy, we also have you must be involved in that. And I know for hand, there's no other place that is tougher to rehab and requires 24 hours a day worth of some kind of movement or strengthening than in the hand,
Well, fortunately, living in Florida, although I will tell you, Caribbeans do not like to get in the water, and Canadians you can't keep out of the water. And I use water as my way of getting your brain and your hand to be back in touch. And that's part of that psychology, but it's also part of the physiology of it. And so I started using water and getting in the pool in the late 80s, because you didn't have people that could go, come into therapy all the time. They didn't have the transportation, etc. So I said, do you have a pool you can get to? A friend, a family, the YMCA. LA Fitness will give you a 3-month membership at $40 a month. Most people can afford to do that, and it gets it closer to their home. Yeah. And the key for me is, if you'll get in the water, I will get your brain and your hand to start working, because you'll automatically keep yourself up above the water to keep from drowning. So it's kind of a passive way, but active way of getting you to use your hands. The other problem with hand is it doesn't matter what you fix that tendon with, it still takes 3 months to heal. And you still have, so unfortunately, we're still constrained by Mother Nature and the organism itself and how things healed. We have not been able to speed it up in the way you can with bone, with a support and a strut, an internal fixation, which acts as a splint, an internal splint. We don't have that ability for everything. You do for distal radius, you do for some finger fractures and things like that, but you don't for a tendon repair, you don't for a nerve repair. These have their own timelines, and they haven't changed. There's nothing that we've found to speed it up. Now that may change with the biologics, but even then, there's only so fast you can make a cell grow. So we're still in where we were 50 years ago.
Good point.
Thank you, Doctor.
All right, guys, any other questions, comments about any of us or any of the other speakers? Yes.
Real quick. This is a question for Dr. Aylyarov. And for meniscal repairs, is there an age cutoff? Because I know back in the day, if you're a certain age, you're not, viable to have a meniscal repair.
No, definitely not.
you're out of the range
Nowadays, especially, we're seeing roots. Dr. Suarez may disagree, but we're seeing root tears in older patients, right? 50, 60, 70-year-olds who have, the cartilage looks pretty good, when you get weight-bearing x-rays and you have really good space, and so, saving them from having to have a knee replacement, their normal kinematics in their knee, it really, and I tell every patient that I see, I don't know what I'm going to do until I get in there. But I'm going to try to repair every single one I can, because we know the long-term studies show that the patient's going to do better. Now, it may fail, and we may have to go back and clean it out later, but I have to look at the quality of the tissue in every case to really decide. And so, yeah, I've done repairs in 50, 60, 70-year-old patients.
So save the meniscus as much as possible. And one last thing, and Dr. Ouellette, I'm glad you mentioned about the psychological recovery, not just for hand patients, but for any patient recovering from injury. And for my years in working in rehab, I spent most of my time on working on that psychology, especially my high-level athletes. When they're sidelined and they're looking at their team playing, they're sidelined, I spent more time recovering them, for that recovery psychologically and getting back out on the field. And that goes for all our patients, getting them back moving. It is critical. When you're dealing with professional athletes, I know they're going to get back because they're phenomenal specimens. That's what get them to that high level. But the biggest hurdle is getting them mentally back on the field as quickly as possible.
Anyone else? Comments, concerns, complaints? Yes, sir. Complaints. I knew it.
So there's different options now. So there's most of them have the braided
The question for
type.
everybody, sorry, the question for everyone in case someone didn't hear is what kind of sutures are we using for meniscal repair?
Yeah, so the majority of the implants now have a strong braided type suture, like a fiber wire, an Ethibond type suture. But you can even use, a lot of the inside outs also use PDS because it resorbs over time. But, again, most of the time people are concerned about those knots, even with the big bulky knots you get with those fiber wire type sutures. I've seen them synovialize over time, and they really don't irritate. As long as you place them in the back, right, not underneath the condyle, in the back of the knee, they'll synovialize over time.
Okay, guys, so now there's going to be lunch, but please keep an eye out because there's also going to be a group photo. So just kind of keep an eye out for that because it's really nice when we get a really nice, good group photo for everybody. Okay? Thank you very much, and thank you to all our panelists.